Okay. Hi, I'm Jill Holtz. I am a clinical psychologist at ASAP, and I'm filling in for Dr. Larissa Maley today. And I will be talking about grief and best practices for working with individuals who are experiencing grief. All right, I'm trying to move to the next slide. What am I doing? So I will be going over the definitions of both grief and bereavement. I will be reviewing models of grief and bereavement and the common symptoms associated with both. We'll be talking about the concepts of traumatic grief and complicated grief. And I'll be identifying the commonalities and distinctions between or among depression, anxiety, PTSD, and traumatic grief. And also finally provide an introduction to evidence-based practices for the treatment of uncomplicated grief and pathological grief responses. Apologize, it's slow. I'm pressing the arrow to move to the next slide and it's not moving. Oh, here we go. Okay, bereavement. This refers to the death of a loved one in its broadest terms. And really, it encompasses the entire experience of family members and friends. It involves the anticipation of death, and subsequent adjustment to living following the death of a loved one. It includes both the internal psychological processes and adaptation, as well as the expressions of and experiences of grief. It also encompasses changes in the person's world and external circumstances, such as changes in relationships and alterations in living arrangements following the death of a loved one. In contrast, grief is a normal reaction to loss. And it refers to the distress resulting from the bereavement. So the bereavement is the death, the grief is the response. Grief is multidimensional. It has physical, behavioral, spiritual components, and it's characterized by a complex set of cognitive, emotional, social, and cultural adjustments that follow the death of a loved one. There's a lot of variation in the way that people experience grief, variation in intensity, how long it lasts, and also in the ways that people experience and express their grief. There's also a lot of similarities, and we do know that grief often involves distress, anxiety, yearning for the loved one, sadness, and preoccupation with the death. The majority of people appear to cope effectively with bereavement-related distress, and most people, this is important to note, most people do not experience adverse bereavement-related health effects. So briefly touch upon theories of grief and bereavement and the way this has changed over time, but it's also influenced the way we do think about it. So we'll start with Freud and, grief, early grief work, being conceptualized as, it focused on breaking attachment bonds with the deceased. And, then there was an emphasis on freeing the bereaved from bondage to the deceased, readjustment to new life circumstances without this person in their lives, and then followed by the building of new relationships and engagement in the environment. Freud believed that if the bereaved failed to complete grief work, they would get stuck in this process. You might be familiar with some of these grief stages, Kubler-Ross, and they were developed, with the idea that people they go through distinct stages in the process of dealing with their grief. Anger and denial, followed by anger, followed by bargaining, depression, and acceptance. And then a second prominent theory is that people go through the stage of feeling disbelief, yearning, anger, depression, acceptance. This notion of, a stage-based grief model has been deeply ingrained in our culture, even though there's really no evidence to support it. Yet it's still taught in medical, clinical and medical programs, but there's really no evidence to support that this is accurate. Where we are today. So as I said, research evidence failed to support the popular notion, which construes grief as a predictable emotional trajectory leading from distress to recovery. Really, there's been a movement away from the idea that successful grieving requires letting go, and instead a movement towards a recognition that maintaining continued bonds with the deceased fosters healthy assimilation of the loss. So that means it's okay. It can be healthy to continue to, think about what that relationship can be, what it can look like, even now as a person continues to move forward in their life. Research evidence has also failed to support notions that grieving is commonly associated with depression, anxiety, and PTSD, or that it's a complex process of working through or engagement in grief work, and that it's critical to recovery. Finally, the absence of grief, and this is very important, is no longer seen as pathological. We understand that people experience grief in different ways. And there are multiple trajectories in grief. Research supports the idea that resilience and healthy assimilation of loss is the most common outcome, and complicated grief patterns are rare. So most people do experience, people are resilient. There are 5 distinct trajectories that have been shown across studies, that of common grief or recovery, also stable low distress or resilience, depression followed by improvement, chronic grief, which we'll talk more about, the persistent complex bereavement, which is the case for about 16% of people. And then another trajectory might be that of chronic depression. But grief is normal. We all grieve at some point in time. Really it's the price we pay for love, and a natural consequence of forming emotional bonds to people, projects, possessions. All that we value, we will lose someday. We lose, and we conceptualize it as, it's grief related to loss of people, but jobs, mobility. It's life's most grievous losses disconnect us from our sense of who we are and can require a relearning of ourselves and our place in the world in order to move forward. Most research suggests the concept of normal grief as a process of making sense and finding meaning in the wake of loss. And, really that the emphasis is on the reconstruction of meaning, and that represents the most critical piece of grief. Acute grief is typically characterized by, numbness, shock, denial, sadness, loneliness, anguish, anxiety, loneliness, and depression, fear, feeling overwhelmed, having waves of emotion, which we might think about as pangs of grief. This typically decreases in intensity and frequency over time. Then we think about integrated grief, and that typically occurs several months after death. Ability to think of the deceased with equanimity and a return to work. So there is, a recognition that you have grieved, ability to think about it with a sense of peace, and an ability to return to life and to work. I'm going to go over some DSM-5 information and talk about complicated traumatic grief and when grief becomes problematic for people. Common mental health conditions following acute or chronic grief include major depression, panic disorder, generalized anxiety disorder, PTSD, and increased substance use or a substance use disorder can also follow chronic grief. Theoretically, complicated grief incorporates elements of both separation distress and traumatic distress. It persists over several months and sometimes years. It can, an outcome can be that it gives rise to numerous negative health outcomes. Yet it's distinct from both depressive and anxiety factors. Complicated grief is associated with sleep disturbances, clinically significant stress, impairment in work and social functioning. It's also, associated with suicidal thinking and behavior. There's great despair and distress associated with complicated grief. And we often see an impairment in relationship functioning. It's also, associated with increased use of substances as a coping mechanism. Risk factors for complicated grief would include not having a lot of social or feeling as though one doesn't have a lot of social support, increased stress, having a positive caregiving experience with the deceased, a history of childhood separation anxiety, some personality correlates, child abuse, having controlling parents, the death of a parent during childhood, having a close kinship to the deceased, a mood disorder. That is a risk factor for experiencing complicated grief. And what maintains complicated grief? Well, a lack of integration of the loss with existing knowledge, so not really making meaning from the experience. There's some maladaptive beliefs and cognitions that might maintain the experience of complicated grief, and then avoiding behaviors, so not allowing oneself to experience the grief and to really process it emotionally. There are two categories of complicated grief disorder. We think about it into symptoms of separation distress as a category, and that would include longing and searching for the deceased, loneliness, and preoccupation with thoughts of the deceased. Then the second category would be symptoms of traumatic distress, and this would include feelings of disbelief, mistrust, anger, and shock, detachment from others, and experiencing somatic symptoms of the deceased. There are similarities, or the way we think about, traumatic grief and PTSD. We've identified some similarities. They're both stress response syndromes, and they both include symptoms of having intrusive thoughts, intrusive ideation, emotional numbness, detachment from others, and irritability and anger. However, there are also some pretty significant differences between the two, between traumatic grief and PTSD. Traumatic grief includes a prominent component of separation distress, and this is typically characterized by yearning and searching and, recollections of the deceased, so having lots of thoughts about the deceased. Individuals with traumatic grief often believe that the grief keeps them connected to the deceased, and or that to grieve less would be a betrayal to the deceased. These are not symptoms that we see in PTSD. Hypervigilance in traumatic grief refers to searching the environment for cues of the deceased, whereas in PTSD, it refers to fears that a traumatic event would be re-experienced. So you can see that when we think about hypervigilance, that's common to both of these conditions, the experience or what's driving the hypervigilance is different. And then sadness is the predominant affect experienced in traumatic grief, whereas fear is foremost in PTSD. And what this slide here shows is that, and that goes over the model of pathways that leads to complicated grief. And you can see that if you're comparing childhood security to an experience or pathway of childhood insecurity. So, you know, having an insecure childhood experience might develop into if a person has an insecure childhood experience, that person might, you know, develop an insecure attachment style that then leads to, like, then the death would threaten, you know, the sense of self, happiness, survival, and that could potentially lead to complicated grief experienced by separation distress and traumatic distress. Whereas if a person experiences a secure childhood, then goes on to develop secure attachments, the death will be experienced as less threatening to the sense of self, happiness, or survival. And that person may experience, you know, well, is likely to experience uncomplicated grief, which would be experienced more natural, what we talked about earlier, which is more acute and integrated. And this has to do with how, you know, the patient or the person makes meaning from the death of the significant other. So in the DSM-5, we talk about persistent complex bereavement disorder. This is the official diagnostic label for complicated grief. And this is characterized by persistent yearning, longing for the deceased, intense sorrow and emotional pain in response to the death, preoccupation with the deceased, and then preoccupation with the circumstances of the death of the significant other. Also characterized by reactive distress to the death. You know, this is characterized by, you know, difficulty accepting the death, experiencing disbelief or emotional numbness over the loss, difficulty with positive reminiscing about the deceased, bitterness or angry related to loss, as well as maladaptive appraisals about oneself in relationship to the deceased or the death. So, for example, it might bring up self-blame. And then it's also characterized by excessive avoidance of reminders of the loss. So avoidance of individuals, places, or situations associated with the deceased. Persistent complex bereavement disorder is also characterized by social identity disruption, which includes a desire to die, which might include a desire to die in order to be with the deceased. You know, difficulty trusting others since the death of the significant other. You know, feelings of aloneness or detachment from others since the death. Feeling that life is meaningless or empty without the deceased, or the belief that one cannot function without the deceased, and then confusion about one's role in life or a diminished sense of one's identity. So feeling that a part of oneself died with the deceased. And then difficulty or reluctance to pursue interests since the loss or plan for the future. So not really engaging in the present and maybe disengaging from relationships or activities that used to be a part of the person's social identity and what they did during, you know, as a part of their life. I'm going to talk a little bit about death by suicide, bereavement after suicide. It's normal. There's a struggle, you know, after bereavement after suicide. Struggle with the questions of meaning making around the death is normal because it's very difficult to deal with the suicide of a loved one. This usually results in higher levels of feelings of guilt, blame, and responsibility for the death. Individuals experience heightened feelings of rejection or abandonment by the loved one, along with anger toward the deceased. And then there's typically less support from social networks when, following, bereavement after suicide. And we typically, people who are in this situation typically experience greater overall grief reactions. It's important to note that 76% of those bereaved by accidental death reported that the changes in social interaction were positive in nature, whereas 27% of suicide survivors reported that changes in social interaction were positive in nature. And so you can see that there are far fewer people who, suicide survivors, that, are able to adapt or report changes in social interaction that can be understood as positive. I just wanted to talk briefly about suicidal ideation in young adults. Studies that have looked at suicidal ideation in young adults who have experienced the death of a friend, it's found to be 5 times more likely to report suicidal ideation than youth who have lost a friend to other types of death. And levels remained high after controlling for depression, gender, and time of death as great as 6 years post. So you can see that it's quite an impact on youth. Studies that have looked at suicidal ideation in young adults who experienced the death of a close family member, we looked at that, and studies have found to be 11 times more likely to report suicidal ideation or to have made at least one attempt in their life. So you can see that suicidal ideation and our young people are very much affected by the death of loved ones, especially when the death is related to suicide, and that's what we're looking at here. Suicidal ideation in adult survivors. Adult survivors are 10 times more likely to report suicidal ideation after controlling for depression. And individuals who develop complicated grief following suicide have an 83% likelihood of developing suicidal ideation. It's important for us to remember that adults, both young adults and adults, are survivors are very much impacted by the suicide of a loved one. So what do we do about this? I'm going to go over some treatment approaches. I'm going to talk about approaches for normative grief and uncomplicated grief. You can tell this is, all right. So this is pretty important to know. There is no evidence that all bereaved people will benefit from counseling, and research has shown no benefits derived from counseling for no other. Let me read that again, or say that again. Colin Murray Park said, "There is no evidence that all bereaved people will benefit from counseling, and research has shown no benefits to arrive from counseling for no other reason than they have suffered a bereavement." And so for the natural response to bereavement, grief is normal. It's a normative response to bereavement, and there's really not a lot of research to show that counseling, for the sake of, helping people who've suffered a bereavement, there's not a lot of research to show that that's helpful. Routine intervention for bereavement is not empirically based, and outreach is not advised unless requested. Intervention too soon after loss may interfere with the natural grieving process. So really what we want is to allow people to experience, to go through the grief, to go through the process as would be natural for them. So normative grief work, as I just said, grief is a normative process and requires much listening and not a lot of intervention on the part of the counselor. So we don't need to refer people to counseling simply because they're experiencing grief. But what do? We allow people who are experiencing grief, normative grief, sufficient time to grieve. Most people resolve grief to a level of prior functioning around 1 year. And some individuals and families will accomplish the task of grieving in 2 years. So providing patients with sufficient time and allowing people to grieve naturally is recommended. Allowing sufficient time and being patient with yourself to allow people to go through the process is important. One thing you can do is advocate for sufficient time from off of work for the bereaved, especially in the first few weeks of bereavement. And also make sure to have that conversation that there are certain times where grief is likely to spike, during times or the holidays, maybe, or anniversaries. There are times that grief is likely to spike, and just to explain to the client that is normal and to expect it and to prepare for it as well. It's also important to emphasize the role of the funeral and the memorial service to encourage families to bring children to these rites and to talk about the loss versus avoid it. To talk with them about abstaining from the use of drugs to medicate grief reactions. You don't need tranquilizers or antidepressants. They're not typically needed for healthy grief. To monitor individuals who have lost, due to suicide or violence, because they are actually at higher risk for grief problems, as we just talked about. And to identify concurrent problems that may interfere with normal grief, such as substance use, which gets in the way of the natural recovery, the normal grief process. And some interventions that you might recommend would be to use a narrative approach, have the client do writing exercises to describe and work through the loss so that meaning can be made. You might ask to tell me, what is it you believe about death? What does this loss mean? Supportive interventions can also be effective, so to facilitate the safe expression of grief and to encourage affect, to experience it. It's okay to cry. Intrapsychic approach, facilitate connections to the deeper wisdom in loss, death as a concept, and talk about, the ability to heal. And then sometimes spiritual support can be quite helpful for people, as who are experiencing normative grief. So it's helpful to encourage clients to connect with religious or spiritual community to process the meaning of the loss. All right, I'm going to talk about treatment approaches for complicated grief or traumatic grief. One approach is I want to go over the dual process model. This was developed from a cognitive stress perspective, and it's really describes grief and grief work as, helping the person to process and shift between two contrasting modes of functioning. In the first, it's a lot, the loss of orientation, the griever in the loss orientation, the griever experiences an emotion-focused coping, and that involves exploring and expressing the range of emotional responses associated with the loss. And then there's the loss orientation, and there's the restoration orientation. And then the restoration orientation, the griever engages with problem-focused coping and focuses on life demands. So it's really about, first engaging in the emotion-focused coping and just experiencing the emotions, processing them, and then moving more into the problem-focused coping and focusing on life and what's happening right now, the life demands. The model suggests the focus of coping may differ from one moment to another, from one individual to another, and from one cultural group to another. And there's also a task-based model. This model considers grief as an active process that involves engagement with 4 tasks and encourages interventions to aid with the 4 tasks, accepting the reality of the loss, processing and experiencing the pain of grief, adjusting to a world without the deceased, including both the internal, external, and spiritual adjustments, and then finding an enduring connection with the deceased in the midst of embarking on a new life. And that's what I mentioned earlier when we were talking about finding an enduring connection. So it's not necessarily about, ending or detaching or abandoning that relationship. It's in finding an enduring connection with the deceased in the midst of embarking on a new life. And that'll mean different things to different people. This model identifies 7 determining factors that are critical to appreciate in order to understand the client's experience. And these factors include, identifying who the person who died was, and the nature of the attachment to the deceased, talking about how the person died, historical, thinking, identifying historical antecedents, personality variables, social mediators, and concurrent stressors. There's an emphasis on continuing bonds, emphasizing, aiding a person to recognize that death ends a life, not necessarily a relationship. And we talked about that before, but what that means will be different for different people. But it's not, death, it's that emphasis that helping a person to recognize it ends a life, not necessarily a relationship. So how can a person continue to have a relationship with the deceased? Also, the idea is rather than saying goodbye or seeking closure, there exists the possibility of the deceased being both present and absent and helping patients to hold this dialectic, rather than saying goodbye. So it's about that it's both. The deceased is both present and absent. And so you can help your client to hold both of these things, at the same time. And that can be helpful as far as healing and moving forward. The expression of this continuing bond can be found in a variety of forms. One way to do this would to be, for the deceased to be seen as a role model. And the bereaved may turn to the deceased for guidance or to assist them in clarifying values. Talking to the deceased, or by relocating the deceased in heaven inside themselves or joined with others whom, they spend time with predeceased. The bereaved may experience the deceased in their dreams by visiting the grave, feeling the presence of the deceased, or through participating in rituals or linking objects. Those are all ways that you can help a client to continue, bonds, or just recognizing that, death ends a life, not necessarily a relationship. So to continue that relationship or bond with the deceased. It's also important to help our clients make meaning from the death of the loved one. This includes helping patients construct a world of meaning that has been challenged by this loss. It's particularly important when the death violates the patient's worldview that life is predictable or that the universe is safe and benign. Sometimes death can seem unfair, unjust, random. And, across a variety of losses, a body of research indicates that the failure to find meaning following the loss, especially in terms of making sense of the death itself, is associated with higher levels of complicated grief symptoms. And we talked about that a little bit earlier. It's very important when you're trying to make meaning from the death of the loved one. So what does this mean? Most definitions of meaning encompass two concepts. The first is making sense of the loss. For example, the death had been predictable in some way. It was consistent with the caregiver's perspective on life or religion or spiritual beliefs provide meaning. So making sense of the loss. And then secondly, finding benefits from the loss. This can be tricky, but it's sitting down with the client and talking about what meaning can you make from this loss? Whether, maybe it's led to growth and character. Maybe you've gained perspective and it strengthens some of your other relationships. So that would be a way to kind of think about, finding benefits. So making sense of the loss, making meaning, and then finding benefits, helping your clients to move toward being able to do both of those things. An EBP for complicated grief is CBT, cognitive behavioral therapy for complicated grief. It involves there are three processes that are crucial in the development and maintenance of complicated grief. First, it's maintained by, according to this CBT for complicated grief, thinking about it this way, complicated grief is maintained by an insufficient integration of the loss into the individual's autobiographical knowledge base. It's also maintained by having negative global beliefs and misinterpretations of grief reactions. For instance, that we have an example on the slide, a person might be stuck with the belief, if I move on, that is a betrayal to the deceased. And so that would be a core belief or a stuck point that's keeping this client trapped and keeps the client from moving forward. So you'd want to help the patient learn to challenge that belief. And then the other process, according to a CBT perspective, that, that's maintaining, what's also maintaining the complicated grief for patients would be engagement in anxious and depressive avoidance strategies. And I talked a little bit about what that is earlier. Maybe avoiding places that used to go with the deceased or things you used to do that you would want to you would want to help the client to do again, because the avoidance is maintaining the complicated grief. So CBT for persistent complex bereavement usually includes an introductory phrase that is 1 to 3 sessions. That includes, there's a focus on establishing a strong therapeutic alliance, obtaining or just talking about in a history, going through the patient's history of interpersonal relationships, providing psychoeducation about grief and bereavement, and collaborating typically with somebody in the patient support system and including them in treatment, session number 3. And that would be important because we know that sometimes people's worlds get smaller when they're experiencing such persistent complex bereavement. So finding ways to increase social support is really an integral part of this treatment. During the intermediate phase of CBT for persistent complex bereavements, the client performs the exercises or does the activities both in session and at home. There's often an imaginal revisiting of the death of the deceased. And that would be including talking about the deceased in session and then listening to tape outside of the session, debriefing with the therapist, and identifying and implementing rewards for approach versus avoidance strategies around grief reactions or reminders of the deceased. So it's really about, identifying what's being avoided and then coming up with strategies and implementing rewards for moving forward in life and maybe doing some of the things that the patient has stopped doing due to the grief that they're experiencing. Questions? That's all I have for you.
So it looks like there is a chat question. It says, Amber here with Marcella, to help the client with the emptiness of losing a loved one, other than techniques of continuing the bond making meaning, what might be utilized or suggested to help with the emptiness? We're asking about a question, but seems weird. Oh, sorry. I think I can hear you guys a little bit, but it's not very clear. But if you wouldn't, can you answer that question for us? Can you see it in the chat, Dr. Holtz?
I cannot see it in the chat. I'm so sorry. I've had such difficulties with the technical features.
No worries. That's
Anything in the chat.
Do you want me to reread it?
Yes, please.
Sure. Okay, so to help the client with the emptiness of losing a loved one, other than techniques of continuing the bond / making meaning, what might be utilized or suggested to help with the emptiness?
So the emptiness, what, can you clarify what you mean by emptiness? Because I think I understand what you mean, but I want to make sure I accurately answer your question. So like the feelings of just related. So can you please clarify what you mean by emptiness?
So they said the client feeling a void or incomplete without the loss of the loved one.
Yeah. And so I think that in that situation, if emptiness, really what you'd really want to try to increase the two things. Really encourage the client to re-engage in life, because there's emptiness, because that might be related, the experience of emptiness might be related to identity. Actually, do you have a case? I want to, or as far as emptiness, let me think. I would encourage the patient to, even though it's hard, and emptiness can be related to, because you're missing something from your life, right? A person would feel emptiness because something's gone, a person's gone, and maybe that person doesn't know who that person is without that person, or the person stopped doing things that the person used to do because the loved one is no longer in their lives. So it would be important for the patient to be encouraged to grieve and to feel that emptiness in a safe way, but then also to continue to encourage the patient to re-engage and to find, small, so who does this person have in the person? I mean, maybe this person, another person in the life can't replace initially the loss of the loved one, but what can that person do to integrate or gain more positive or rewarding, reinforcing experiences with other people? But it's a gradual process. And so it's just, what else can that person do? But still allowing that person to, or really encouraging that person to experience the loss. What does that loss mean? And talking about the emptiness.
So this pick for them was, my current client lost her daughter in May and now feels that her heart and personality is not whole with the daughter gone.
Yeah, that's really hard. And that's a really good question. Yeah. So I would really, I would probably and encourage or talk about the relationship with the daughter and really explore that relationship and what it meant for the patient. And then as you're talking about it and exploring it and spending time going there, I would, at the same time encourage the patient to find other ways or other things. And again, it's never going to replace the daughter. Nothing will ever replace. So accepting that, because there's some acceptance work that accompanies that needs to happen as well. And I didn't really go over that in the slides, but accepting the loss, it's really hard. But slowly finding other people while talking about this relationship and maybe using the narrative that I went over briefly, just talking about it, writing about it. What does this mean? What does it mean to no longer have the daughter in your life? And then slowly moving on and trying to find other things that the patient can experience, or that can help the patient to move forward. Because in some ways, I think when the loss of a child brings up a lot of identity issues, who am I without the child? Is someone writing on the screen? Okay. Yeah, I hope that was a little bit helpful at least.
The response was, that helps what was said. I think re-engagement will be key in letting her know that she can't replace her daughter, but can get new bonds and interests.
Okay, good. Anything else?
If there's nothing else, we'll go ahead and wrap up. I will send the follow-up email with all the information for all the registrants for your CEUs, as well as the information from the slides today. But thank you guys very much for joining us. And if you need anything, you can email us here at STR at the email that you receive all your registration from. But thank you again, Dr. Holtz, for helping out and filling in today. We really appreciate it.
Well, thank you. Thanks so much.